All right, continuing our discussion in terms of joints, let's talk about the intermediate joint of the upper limb, the elbow joint. And really when we're talking about the elbow joint, it's actually a composition of 3 joints within one joint capsule. Now what we typically think of as the elbow joint with this flexion extension movement is the humerO-ulnar joint. But the humeroradial joint is considered part of the elbow as well as the proximal radio-ulnar joint. And we'll talk about all 3 in time. So when discussing the elbow joint, we want to focus on the distal humerus in this region right here with the condyles, and then the proximal ulna. So with this more complex region in terms of the ulna as compared to the less complex region of the radius. So when we're discussing the trochlea, that's going to be medial. And you can always tell it's medial because the medial epicondyle is quite a bit more robust than the lateral epicondyle. You're going to have the capitulum as well, which will play a role for the radial portion or the humeroradial joint. With the humerO-ulnar joint, the ulna obviously is the other bone in the equation. You're going to have the trochlear notch, which is this semilunar portion right here, the coronoid process, which is this distal portion, as well as the large olecranon. And sometimes you hear the olecranon referred to as just the olecranon. Sometimes you'll hear it referred to as the olecranon process. That's the thing about anatomy. We have 1,000 names for one thing. It's this pointy portion that you can palpate on the back of your elbow. Now, let's talk about what this actually does in terms of movement. So when you're talking about the humerO-ulnar joint, this is the true hinge joint with flexion and extension. So let's watch these movements. So you can see we're moving in terms of a sagittal plane as you would with most flexion and extension movements. Here is a lateral view here. So flexion, you're moving anteriorly. Extension, you're moving back into anatomical position. Now, like any hinge joint, you're going to have strong collateral ligaments. This will keep the movement of the flexion and extension and not allow for any deviation medial or lateral. So in terms of this, you're going to have the ulnar collateral ligament, which is obviously on the ulnar side. This is considered a capsular ligament, so actually a component or a thickening of that articular capsule. And as you can see here, it's a fairly robust ligament. So this is going to afford more stability than its partner on the lateral side, the radial collateral ligament. Now, one thing that we want to note in terms of the radial collateral ligament, because this will come back in terms of the proximal radio-ulnar joint, is that it's attached to this ligament right here. And this is referred to as the annular ligament of the radius. So if you recall from our discussions of the bone, and you can see here in this visual, the head of the radius is almost like a little button on top. It's fairly shallow in its most proximal portion, and it has a ligament that completely surrounds the head. Well, this radial collateral ligament is going to attach to that annular ligament, so affording more protection there as well on the lateral side. Okay, so next to the humerO-ulnar joint, you're going to have your humeroradial joint. And let's take another look at this right here. So you have, over here is your trochlea, which we just discussed in terms of the humerO-ulnar, and over here is your capitulum. The capitulum is a bit more bulbous, whereas the trochlea is more spool-shaped. The capitulum is going to be a bit more robust. And you have that shallow proximal end of the radius that's going to be able to move with the humerO-ulnar joint. So when you're doing that flexion and extension that can occur, the humeroradial joint is moving as well. Now, in terms of its classification, it's been classified as numerous things. Most of the literature now is going to refer to it as a hinge joint, similar to the humerO-ulnar. Sometimes you can actually see this joint is referred to as a ball and socket joint. Now that is something that's a bit harder to understand because you're not having any of the abduction or adduction other than very slight movement. So if you do have a movement medial or lateral, it's typically occurring at this humeroradial joint. All right, now also within that joint capsule, you're going to have the proximal radio-ulnar joint. So this obviously, as the name would suggest, is going to be made up of the radius, specifically that button-shaped head, as well as the ulnar or the radial notch of the ulna. And it's just shallow region right here on the lateral side of the ulna. Now those two bony parts are going to fit together and be stuck together by this annular ligament that we saw in the previous slide, which is surrounding the entirety of the radial head. Now I said this is actually a component of this joint capsule, but it's going to have a completely different movement. So let's look at this actual position right here where they're actually connected. So this is what we're talking about in terms of the proximal radio-ulnar joint. And there's that annular ligament right here. So very important in terms of keeping that within those two bones together within that larger capsule of the elbow joint. All right, so what does this joint do? Now, it's not part of that typical hinge movement, the flexion extension. This is where that unique movement of the upper limb, pronation and supination, can occur. Okay, so this is going to occur at this proximal radio-ulnar joint as well as the distal radio-ulnar joint, which we'll talk more about when we talk about with the wrist. So let's talk about what pronation and supination truly is, and let's look at a video here. So you see we're in anatomical position. Now pronation, you can see the palms are facing backwards. They're facing posteriorly, where with supination, palms are facing anteriorly, so an anatomical position. So when you're in an anatomical position, you're supinating. What that means is that the radius and the ulna are parallel to one another. Whereas with pronation and the palm facing posteriorly, that radius is going to be rotating over the ulna. The radius is the moving bone. The ulna is going to stay in place, in part because it's so stuck due to the elbow joint. So radius is moving, ulna stays in position. Okay, let's consider some of the clinical considerations associated with these intermediate joints of the upper limb. And the most common in terms of injuries in this area is typically what's referred to as a subluxation of the radial head, which is just a fancy way of saying that this joint is actually going to be dislocated, specifically that proximal radio-ulnar joint. And what happens is that this is going to be referred to as a pulled elbow. So let's consider a situation. You have a kid, say 3 or 4 years old, that's about to run into a parking lot. So a parent immediately is just going to pull on their arm in order to get them out of the way. But what can happen is what's referred to as this pulled elbow. So that radial head, or that button-shaped head of the radius, is going to pop out of the annular ligament. The reason for that is because in juveniles, that the ligament actually grows faster than the radial head. So you have this larger annular ligament allowing for ease of that radial head to be pulled out. Now it's a fairly quick fix. You put the radial head back in. Of course, a physician should do so, but it's a fairly common thing that's seen. You can see it in juveniles, typically between the ages of 2 and 5 is the most common. So that's one of the more common clinical considerations in this area of this intermediate elbow joint. Now we're going to continue our discussion in terms of the more distal joints of the upper limb, the wrist, as well as the joints associated with the digits.